So now we are on live. We are good to go now.
Thank you. Madam, we'll start. Hello, good afternoon, doctors. Welcome to this experience sharing program on managing PPH, case studies from labor room. This program is brought to you by Heathrow Healthcare. Heathrow Healthcare has 25 years of excellence with 36 state-of-art manufacturing facilities. Heathrow Healthcare has 300 plus products in portfolio and presence in 126 plus countries. With 21,000 employees globally, Heathrow Healthcare is the largest closely held pharmaceutical company in India and is among the largest manufacturers of ARV, APIs, and FDAs in the world. Heathrow Healthcare is Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Heathrow Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today's program, Experience Sharing Program on Managing PPH, case studies from labor room. We have got Honorable Speaker Dr. Lata Karuparthi with us. Welcome, Madam. Dr. Lata Karuparthi is MBBS DGO from currently with Lata Hospital, Bhavanipuram, Vijayawada. Madam is undergraduate from Guntur Medical College, Guntur, postgraduate from Rangareja Medical College, Kakinada. Field of interest include high-risk pregnancy, infertility. Part of the team which conducted APCOG 2015, Madam was treasurer, UFOXI 2018, executive member VOGS since 2015, treasurer VOGS 2016, secretary VOGS 2019. Currently Secretary of ISO PRB Society, Vijayawada. With this brief introduction, I hand over the session to Dr. Lata.
Thank you, Doctor. Thank you so much for that kind introduction. So, we'll be discussing on the topic of postpartum hemorrhage, which is really a daunting event. Am I audible? Hello?
Madam, yes, madam. Very loud, clearly.
Okay. So we'll be talking on postpartum hemorrhage, which is which causes a very daunting event, and it should not occur to anyone. So PPH, what is PPH? The postpartum hemorrhage is loss of at least 500 ml of blood during normal vaginal delivery and more than 1000 ml of blood loss during cesarean section. So it's common and can occur in any woman, especially those who don't belong to high risk also. So we should be prepared for every case to prevent PPH during the delivery time, because it is the most common cause, leading cause of maternal mortality in low-income countries and a primary cause of nearly 1/4 of all the maternal deaths globally. Next slide. So as we can see, it's very unfortunate, fortunate, but yet very common to have PPH in our labor rooms, and it causes a leading cause of maternal mortality of about 35% of all maternal deaths. And the maternal mortality rate in developing countries was 240 per 10,000 per 1 lakh live births compared to 16 in developed countries. So it's very common in the developing countries. And it's a global PPH incidence is almost 14 million women suffer from PPH. Incidence of PPH is reported to be 2 to 4% after vaginal delivery and 6% after cesarean sections. What is the incidence of PPH in India? Coming to India, 38% of the maternal deaths are due to PPH, and 25.7% of global deaths take place in India, and 2/3 of these attribute to PPH. So India has an unexpectedly high maternal death rate of about 540 per 1 lakh live births. Next. So coming to the etiology, what causes postpartum hemorrhage? The common mnemonic is 4 T's, which includes the tone, thrombin, trauma, and tissue. Tone, which represents the uterine atonicity. The inability of the uterus to contract and retract properly leads to continuous bleeding. And coming to thrombin, the coagulopathy's failure in that is the failure in clotting leads to excess blood loss during delivery time. Trauma, injuries to the birth canal, rupture of the uterus or inversion of the uterus, and other lacerations in the perineum can cause excess bleeding. In the same way, tissue like retained placental bits, retained clots, or retained products of conception in the even during the second trimester or early pregnancy also leads to postpartum hemorrhage. Next. So what are the clinical findings in PPH? So clinically, when there is the degree of shocks, as we can see in the table, if the blood loss is less than 1000 ml, that is well compensated by the woman. And the blood pressure, there is no change in the blood pressure. There is no signs and symptoms of palpitation or dizziness or tachycardia. Mild will be there. But in the mild case of PPH, almost the blood loss is almost 1000 to 1.5 liters. That is almost 15 to 25%. In the moderate, almost 1.5 to 2 liters. And in the severe, more than 2 liters of blood loss is there. And there is hypotension, tachycardia is seen in the severe variety. And the signs in collapse and air hunger and inuria is seen in the severe type of shock followed by because of the PPH. And in a moderate case, there is restlessness, pallor, oliguria. In the mild, there is weakness, sweating, tachycardia is there. So one should anticipate PPH and should uh, diagnose it as early as possible and treat the postpartum hemorrhage. And the most important is to prevent PPH. Prophylaxis is very important. So the patients who are of high risk of having PPH should be tackled uh, with the prophylactic measures, and PPH should be avoided. So at the time after the delivery, we should monitor the abdominal tenderness, abdominal girth, circulatory collapse, the uterine contractility, maternal tachycardia is there or not, vaginal bleeding, excess or old blood is coming. We have to differentiate. Next. So approach towards postpartum hemorrhage. Can you make it a larger screen, full screen? Dr. Prashant. Excuse me? Can you make it a larger screen? Full screen? Full screen. So we have to rule out about the atonicity. We have to find out whether the uterus is very in a patient with uterine atonicity. There is the abdominal girth is increased. The uterus is very relaxed and boggy and soft. The fundus of the uterus is very much elevated above the umbilicus. And on investigations, blood count should be done. The coagulation profile should be done. Abdominal scan should be taken, and the urea electrolyte should be taken. So it has to be managed by uterotonic agents like OX2, 6, prostaglandins, and ergot alkaloids. And also, depending upon the hemoglobin level and all, we should give blood transfusion as early as possible. And also, to control the atonicity, we have to do uterine massage, and uterine balloon tamponade also helps a lot in controlling the PPH. In a case where there is trauma, the bleeding site should be located through proper visualization, and the rupture or the tears should be the extension of the tears should be properly inspected, and that should be sutured with appropriate suture material. Not only in the external in the perineal region, but also you have to inspect the cervix, as well as in the case of normal delivery, cervix and the wall should also be examined, followed by the lower part of the lower uterine segment should also be palpated to show to look for the continuity. And during the cesarean section, the angles of the uterine incision should be looked in, and the other bleeding spots should be identified and sutured with appropriate suture material. And ultrasound, we can take the help of the ultrasound to identify any other fluid collection in the patient's abdomen. So coming to the retained products of membranes or the placental cotyledon remnants, they should be diagnosed by bimanual examination when the uterine size is more than the expected. Then we have to confirm it by ultrasound, and then followed by manual evacuation has to be done, or by instrumental evacuation should be done. And coagulopathy, the bleeding disorder should be diagnosed through proper blood investigations, full blood count, and APTT, PT, APTT should be done. Coagulation profile should be done, and appropriately managed with proper blood products and whole blood, depending upon the blood loss. Next slide. So what is the rationale for the development of carbetocin in new heat-stable formulation? Carbetocin is available in a room temperature stable formulation and is convenient while presentation. So it is stable at room temperature. It has a shelf life of 24 months at 30 degrees and 75% humidity, and it avoids the need for cold chain storage and logistics. It is provided in a vial, but uh, as compared to the oxytocin and methergin or ergot alkaloids, which should be refrigerated to avoid degradation. It should be the heat stable formulation of oxytocin is currently not available, and the previous formulation of carbetocin should be stored at 2 to 8 degrees centigrade. The resource poor countries do not always have cold chain transport and storage capacities. So definitely the carbetocin is definitely it's very useful for the developing countries where uh, this cold storage transport facility is not much available. So what are the uses of uterotonic agents? What are the uterotonic agents which are useful for preventing PPH? These are the molecules are the oxytocin, the carbetocin, the ergometrin or the ergot alkaloids, the symptometrin, which is a combination of ergometrin and oxytocin, and the misoprostol, which is the uh, e- prostaglandins. So it should be delivered at the crowning of the baby's head, at the delivery of the anterior shoulder, at the end of the second stage of labor, and following the delivery of the placenta. It should be prophylactically. It helps in the prevention of PPH. It's the active management of third stage of labor, and therapeutic use is management of PPH. All these molecules, especially they should be given at the delivery of the soon after the delivery of the anterior shoulder of the baby to prevent PPH. And if the bleeding is excess, we can also give a second dose soon after delivery of the placenta. Next. So carbetocin is a next generation drug for PPH management. The molecular um, the molecule is the analog of oxytocin. It is a long-acting analog of oxytocin. It is used for prevention of PPH due to uterine atony. And the one vial contains 100 mcg of carbetocin in 1 ml solution for injection. It prolongs the half-life and it reduces the enzymatic degradation. This was created by making several modifications in the oxytocin structure. So it is active till 90 minutes of administration when compared to oxytocin, which is a very short acting molecule. Next. So as you can see in this slide, the difference between the oxytocin and the heat stable carbetocin. Both these are the synthetic cyclic peptide form of the naturally occurring posterior pituitary hormone is the oxytocin, whereas in heat stable carbetocin, it is a long-acting synthetic analog of oxytocin with agonist properties. And this oxytocin should be given IV, almost immediate action with peak concentration after 30 minutes. And in this intravenous carbetocin, there is a sustained uterine contraction within 2 minutes and lasting for about 6 minutes and followed by rhythmic contractions for 60 more minutes. After giving IM injection, intramuscular, there is a slower onset of action taking 3 to 7 minutes, but produces a longer lasting clinical effect of up to 60 minutes with oxytocin, and the half-life is 1 to 6 minutes. With the carbetocin, the giving IM, sustained uterine contractions lasting for about 11 minutes and rhythmic contractions for 120 minutes, and the half-life is almost 40 minutes. And this can be stored up to 30 degrees centigrade, but in oxytocin, it should be stored between 2 to 8 degrees centigrade, and it should be protected from light is very important to preserve its activity. Coming to the clinical indication, for induction of labor, oxytocin can be used, but not the carbetocin. Augmentation of labor, oxytocin can be used, but not carbetocin. And prevention of PPH, it can be used. Both can be used for prevention of PPH. And for treatment of PPH, oxytocin is advised and not the carbetocin. Next. So coming to the carbetocin clinical trial, it is non-inferior to oxytocin. The WHO champion trial that is the Carbetocin hemorrhage prevention, the largest clinical trial in the prevention of PPH. This trial was conducted by the WHO Department of Reproductive Health and Research. The study design had non-inferiority double-blind randomized trial. The objective was to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. The patients enrolled were almost 30,000 women across 10 countries, including India. The primary outcomes were the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents, and the proportion of women with blood loss of at least 1000 ml. Next. So what were the parameters? The parameters was the blood loss of more than 500 ml or the use of additional uterotonics. In carbetocin, the efficacy was almost 14.5% and oxytocin 14.4%. Then the blood loss of more than 1000 ml, the non-inferiority established was 1.51% and oxytocin 1.45%. And the safety with carbetocin was almost 4.9% when compared to oxytocin, which was 4.7%. At least one serious AE was seen with 0.7% and 0.6% adverse effects. The frequency of the expected adverse effects did not differ significantly between the two groups. The frequency of blood loss of at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior versus the oxytocin. The use of additional uterotonic agents, interventions to stop bleeding, and adverse effects did not differ significantly between the two groups. So to conclude, carbetocin was non-inferior to oxytocin for the prevention of blood loss for at least 500 ml or the use of additional uterotonic agents. So the Cochrane review says that carbetocin for preventing PPH, that for women who undergo a cesarean section, carbetocin resulted in a statistically significant reduction in the need of therapeutic uterotonics compared to oxytocin. Also, carbetocin is associated with less blood loss compared to symptometrin in the prevention of PPH for women who have vaginal deliveries and is associated with significantly fewer adverse effects. So the guideline recommends, what are the different guidelines for preventing uterine atony? WHO 2018 guideline for PPH prophylaxis says only one of the following should be used: oxytocin, carbetocin, misoprostol, ergometrin plus methyl ergometrin or the methyl ergometrin, oxytocin plus ergometrin. It's a fixed dose combination. So the carbetocin is better. And SOGC of Canada also recommends carbetocin 100 micrograms IV bolus. The New Zealand RANS COG also recommends carbetocin, which for the active management of third stage of labor. FIGO also recommends carbetocin, one of the recommendations for PPH management. Even FCOG France also states that carbetocin on proving non-inferiorly to the oxytocin, which was achieved by Champion trial. So I had a patient of 26 years, second gravida, with previous one live child. She was admitted at term in active labor, which is she was a unbooked patient. On admission, she was pale with a HB of around 8 gram percent, and the other vitals were normal. She delivered vaginally, a single male baby with good APGAR with weight of 3.75 kgs. But she developed atonic PPH soon after the expression of the placenta. And she was managed with uterine massage followed by syntocinon drip. But at that time, carbetocin was not available immediately near the laboring table. So it was again attained. It was in the other room. So it was used again. And the PPH was controlled soon after giving carbetocin injection. And there was no secondary PPH because even after 6 hours, there was no such excess bleeding in the patient. And postnatally, we improved the HB by giving the FCM injections and discharge her with good blood levels and proper contracted uterus. So in the second case also, it's a post-cesarean pregnancy with the first child uh, almost 5 years old, I think. And she was for elective LSCS, and soon after delivery, she developed PPH. The uterus was retracted well, but bleeders were seen at the placental bed. After, we usually give carbetocin regularly for all the patients, and the after giving carbetocin, bleeding subsided and the uterus remained contracted for a long time. So bleeders present at the ankle were secured with number 1 Vicryl, and hemostasis was maintained. So post-operatively, her HB was checked and oral hematinics were given, and at the time of the discharge. This is an interesting case. A 40 years old woman. She conceived with IVF, and she was admitted for cesarean section in view of elderly priming with 35 weeks gestation with dichorionic diamniotic twins with GDM and hydramnios. So she was posted for primary LSCS. After the delivery of the second baby, both the children were delivered with good ABGAR. They were handed over to the pediatrician. And after the soon delivery of the second baby, delivery of the anterior shoulder of the second baby, the carbetocin was given, and prophylactically in view of over-distended uterus. The placenta was delivered out without any excess bleeding, and uterus was retracted well, and there was no PPH. I was very afraid with this case because she was also obese and having GDM with hydramnios. I was very well prepared for that patient. We even arranged one blood for if required at the time of delivery, but there was no need for any blood transfusion.
That's very interesting, madam, especially the third case. Despite having so many risk factors, everything, by God's grace, everything went off well.
Yes, yes.
Yes. Madam, what is the benefit? Coming to the panel questions.
Yes.
What is the benefit of using carbetocin as first-line drug to prevent PPH?
Yeah, of course, I have been using carbetocin as the first line drug now since a long time, because we can avoid using other drugs like oxytocin and other drugs. With the
Correct.
first attempt only, we can prevent PPH.
Correct. And so preventing, and madam, sorry, generally use IM form or IV form?
IV.
IV. And which patient profile can doctors where you can anticipate PPH?
Yeah, as I said previously, those patients who are having over-distended uterus, especially the uterus is enlarged with a big baby, or having hydramnios, yeah, multiple gestation, or if the patient is having GDM and PIH also, they can have PPH. So we should be well prepared for that.
Anemia could be a major risk factor
Yeah,
in our
yes,
country.
anemia
Yes.
also. Yeah, anemia.
Yeah.
Because for them, even a small blood loss is very detrimental for their
can
to
disturb the
maintain their vitals.
hemodynamically. Yes. Which is why you have given iron injection after the delivery in the first case.
Yes. Safe side. She was an unbooked case. Even just we didn't have much time to do all the investigations. She had some papers which were which almost 3 to 4 months back reports were available. So we gave one blood sample and took her to the labor room and delivered out.
Absolutely. And anemia is very common in our country. I mean, we have seen patients with 5 and 6 hemoglobin.
Yes.
I mean, that low, yeah. Any experience of using carbetocin in RH negative mothers?
Yeah, I have been using carbetocin in RH negative mothers also.
It wouldn't be any risk.
So there is no contraindication, I suppose.
Correct. Generally, the doctors use oxytocin for labor induction. In such a scenario, can a doctor use carbetocin for prevention of PPH?
Yes, why not? It can be used. Of course, the original oxytocin will work only for a small time, but this thing will be taken over by carbetocin, which will block the receptors for a much longer time.
Oxytocin half-life is anyway short, so the effect will not be long last. Now, you generally prefer IV route, but is there any scope for IM route, any place in therapy for IM route?
Yes, it can be given IM. The previous slide has
Yeah.
written it, but I usually give IV route only.
IV, yes. Now, because why about this question? Because in the periphery, sometimes the facility is not available. IM route is one which could be, I mean, the only option available in
Mm.
some places. How well is carbetocin tolerated?
Yeah,
Any your experience
I
side
haven't
effects?
seen any side effects with carbetocin.
God
All my
bless.
patients are fine. I have been using it since a long time, many
Yes,
months.
very nice, very nice. And that too IV.
Yeah, IV only.
Yes. And PPH is one condition where the last thing we want is the side effect of a drug.
Mhm. So I didn't face any side
Good,
effects
good,
with the
good.
drug.
God bless.
Yes.
If a patient is not responding adequately with carbetocin, what other additional uterotonics you would use in your order of preference? Huh?
Yeah, usually the next step is we go for this methergin or prostadin.
Prostaglandins, yes.
Yeah, prostaglandins should be given.
Yeah,
And then we go for surgical methods like beading
of
stitches and
course, yes, yes, yes. Let me just see what we answer. Should carbetocin be kept as a reserve drug or should we use the first line? You're using it as
first
a first
line.
line, but it's your first
Should
line.
be the first
Yeah.
line.
Why keep a reserve drug? I mean, when the PPH is such a life-threatening condition.
Yes, yes.
And to conclude, what is your overall experience of using carbetocin? Take home message to the audience.
Yeah. Previously, I was using only oxytocin. Soon
Huh?
after the baby delivery, only oxytocin was the drug of choice. I didn't know about carbetocin and I was reluctant to start with carbetocin.
Obviously, yes, yes, yes.
So with oxytocin, previously my patients they used to bleed after one of few patients they used to bleed after 4 5 hours. So
Oh,
we per vaginal we have
yeah, yeah,
to
correct, correct.
monitor. With after starting carbetocin, I never had a patient with bleeding PV after delivery. So
Very good.
every uterus was very well retracted, well contracted, and there was no excess bleeding or PPH. Any
Possibly
hemorrhage
the
was there. So
possibly the
I recommend using carbetocin as the first line of drug
wonderful.
for prevention of PPH soon after delivery of the anterior shoulder of the baby, at the time of normal delivery, and even at the time of cesarean. Even the
Wonderful.
placenta also gets separated very easily with after giving carbetocin.
Correct. I mean, thank you so much, madam, for your experience. Those case studies were really wonderful, especially the third case study. I really, patient with such a high risk and
Uh,
diabetic.
for
And yeah,
that
yeah,
patient, I was really very
yeah,
much
really,
surprised,
really,
very
really.
much
Then I,
tensed out. I was prepared with everything. I had an other extra doctor was available with me.
absolutely, yeah, yeah.
Bloods were available. I was very much prepared, but thank God nothing uh,
Absolutely, really, really.
happened.
I mean, when I was reading the case study also, I mean, this was the case study which really took my interest also. Thank you so much. Madam, thanks for sharing your experience. It was wonderful. This is exactly what doctors want. The experience from our doctor. Thank you so much. And thank all the doctor who took time from their busy schedule and attended this webinar. Thank you, marketing sales team of Hitro, and thank you, IT team for your IT support. Thank you so much. Madam, you can log off, madam. Thank you.
Thank you. Thank
Sign
you
off.
for so
Thank you
much
so
for
much,
giving me
madam.
this
Of
opportunity.
course,
Thank you.
madam. Most welcome. Thank you so much. It was a lovely webinar. Thank you.
Thank you.
You can sign off, madam.
Thank you, sir.
Thank you.
Thank you so much. Thank you,